Hi, my name is May. I'm a nurse. I am diagnosed with BPD. Everyone in their lives may present as emotional, have fluctuating emotions one way or another. What differentiates people who are diagnosed with BPD to those who are not is that people who are not will not present frequent mood swings throughout or thoughts of self-harm on a regular basis. The symptoms of BPD are woven into our psychopathology, and so these behaviors differentiate greatly from those of the general population. Now, what exactly is BPD? BPD is characterized by 9 symptoms. These are a tendency to act impulsively without the thought of the consequences, a rapid fluctuating mood swings, and these tend to be unpredictable. People diagnosed with BPD have sudden emotional outbursts, and these behavioral explosions cannot be controlled. They lack impulse control, disturbance of self-image, and changing aims and preferences, chronic feelings of emptiness, and tendencies to self-destructive behaviors and suicidal gestures and attempts, and dissociative states in situations of stress. These are included in the symptoms of the checklist of BPD. Now, there are 2 types of emotionally unstable personality disorder. One is the impulsive type, characterized by predominantly impulsive behavior and emotionally unstable behavior, and the second one is the borderline type, characterized mainly by disturbance with self-image, aims and preferences, chronic feelings of emptiness, intense and unstable interpersonal relationships, and a tendency to destructive behavior and suicidal gestures and attempts. To be diagnosed with BPD, a person needs to present 5 or more of these symptoms. That leaves hundreds of possible presentations of BPD. The emotional dysregulation is a core characteristic of BPD, where patients show emotional sensibility. These sensitivities can get easily triggered and need more time to get to the emotional baseline. They also show an inability to regulate intense emotions. Marcia M. Lennon, who herself was diagnosed, or is, I'm not sure about her diagnosis at this moment, if it's in remission, proposed that the development of BPD occurs within an invalidating developmental context characterized by intolerance towards the expression of private emotional experiences during childhood. Thus, as a direct consequence, children do not learn to correctly label, identify, and regulate these emotional states. They're not thought to tolerate intense emotions. Children in this adverse environment tend to alter between emotional inhibition and emotional lability. Hughes and colleagues have proposed the role of lacking of social proximity or responsiveness from revelant caregivers as an integration to the etiopathogenic model of the development of BPD symptoms. This might in turn impair an individual's regulation of their emotions, which has been proposed as a mediator between BPD and childhood trauma. So let's look into what a trauma actually is. Trauma is defined by a severe and lasting shock and pain caused by an extremely upsetting experience or experiences. In the clinical world, there are 2 distinctions to be made: big T and little t traumas, which are not always used because a lot of clinicians do not accept the differences between big T and little t traumas because it shows that little t traumas are not big traumas enough to have a lasting impact. A big T trauma would be defined by a life-threatening event or situation as a car accident, sexual assault, violent crime, or a natural disaster. Death of a loved one or chronic exposure to traumas would also qualify as a big T trauma. Small t traumas, on the other hand, would refer to events that don't involve violence, serious crime, or disaster, but will still be distressing for the individual experiencing it. Examples of these traumas would be breakups, death of a pet, losing a job. While these events do not pose immediate threats to a person's safety, they can still produce the same trauma response of a big T trauma. In fact, there is evidence to show that repeated exposure to multiple small T traumas can cause more emotional harm than experiencing one big T trauma. People who have encountered multiple and longer doses of trauma are at greater risk for developing traumatic stress. In addition, people are more likely to encounter greater impairment and distress from trauma if that trauma occurs with significant intensity and continues sporadically or increasingly for extended periods. Cascading traumas occurs when there are multiple traumas happening in a pattern that does not allow an individual to heal from one traumatic event before another one occurs. Fact of the matter is, it does not need to be compared to another person's trauma with the same disorder as you. What is important is how your body reacted to said traumatic event or events. Emotional dysregulation is heavily linked to trauma responses. Individuals affected by traumatic events show difficulties regulating emotions such as anger, anxiety, sadness, and shame. This is more so when a trauma occurs at a young age and show this as an ongoing pattern. Efforts to regulate one's emotions can be engagements in high-risk or self-destructive behavior, disordered eating, compulsive behaviors such as gambling or overworking or overeating, repression or denial of emotions. Symptom overlap has been reported between BPD and disorders of stress, especially CPTSD. Otherwise known as disorder of extreme stress, not otherwise specified. This disorder shares multiple similarities with BPD, including pathological dissociation, somatizations, dysregulation of emotions, altered central self, and relational schemes. This is followed after prolonged traumatic situations. There has been research recently which tries to determine if CPTSD and BPD comorbid with PTSD are distinct or should be considered and named as trauma-related disorders. There has also been a review which discusses mechanisms in which childhood trauma is related to developing BPD and its mediators of developing it. Several studies show that about 30 to 90% of people diagnosed with BPD have reported child abuse, more than any other personality disorder. In a recent study, Martin Blanco and collaborators have found that there was a correlation only between childhood maltreatment and sociability and high neuroticism, anxiety traits, and the presence of severe emotional abuse was associated with the severity of the disorder. There have been many studies showcasing a relationship between childhood trauma and BPD, including one where they looked at records of 751 psychiatric patients diagnosed with personality disorders and found that 93% of patients diagnosed with BPD reported at least one type of loss or abuse in childhood, compared to 74% of patients with other personality disorders. An even larger discrepancy has been found in a pilot study by Oldham et al., 75% to 33%. Another study by Gollier et al. Found that psychiatric outpatients diagnosed with BPD have had significantly higher rates of childhood physical abuse at 53% compared to other personality disorders. But they did not find the percentage to differ greatly with reports of sexual abuse, 29 versus 19%, though still higher. On the other side, Bradley et al. Had healthcare professionals describe 534 patients in total and found that childhood sexual abuse to be a significant predictor of BPD over family environment, which also was a significant predictor. Still, Silk et al. Found that the severity of sexual abuse was predictive of certain aspects of BPD, including parasuicidal behavior, regression in therapy, and total score on the diagnostic interview for borderline patients. A study by Helgeland and Torgerson found 5 variables in distinguishing BPD patients from patients with other Axis 1 and Axis 2 disorders. Abuse, neglect, environmental instability, paternal psychopathology, and having few protective factors. Patients diagnosed with BPD reported significantly more types of childhood trauma, greater use of healthcare services, and high numbers of self-harm behaviors. Furthermore, childhood maltreatment is said to be a critically important etiological factor within patients with the same psychiatric diagnosis. It shows that maltreated individuals present early onset more comorbidities, worse clinical course, and alterations in the structure, function, and connectivity of stress-susceptible brain regions. A healthy developing brain is required to be exposed to specific but expected stimuli, but also protection from threats or stressors that might overwhelm the developing brain during early postnatal development and adolescence. Thus, caregivers play an important role in providing the necessary stimulation but also protection against effects of stress. A secure attachment is necessary for this. If this is not given, it has damaging effects on the development of the brain. Adolescence is also a peak period of vulnerability to the emergence of psychiatric disorders and is at a heightened risk by susceptibility and maltreatment and bullying. Moreover, the type of attachment bonds performed during infancy and childhood form a base to the future relationships and influence of person's ability to perform and maintain healthy social connections throughout life. In a study comparing emotional dysregulation and impulsivity in BPD and ADHD, detected associations between trait impulsivity and childhood traumatization mediated by emotional dysregulation. A potential explanation for the ADHD-like characteristics in BPD can be trauma-related. Traumatization can make children feel agitated, troubled, nervous, alert, restless, symptoms that seem like inattention or concentration problems. Symptoms that seem like inattention or concentration problems in traumatized children can be symptoms of dissociation or avoidance of traumatic reminders. Traumatic events in childhood, especially ones that affect emotional maturation, are considered disposing factors of developing emotional dysregulation and impulsivity later on. In this study, Kenzoli et al. Found out that the ones who are highly traumatized had the highest delay aversion, not waiting for the bigger reward later, but taking the smaller reward sooner. This association gives a potential insight to coping with a chaotic, traumatizing milieu. Where the future is not predictable, the short-term gains becomes more important, and therefore it can be considered as a relevant coping strategy. Most studies about BPD and childhood trauma work with retrospective methods. Prospective studies eliminating recall bias are rare. Yet, notably, there was a study by Bornavolova et al. Is a great example of study that is consistent because they chose a unique population of inner-city primary African American substance users, a totally different demographic of typically white middle to upper class individuals, and they still found correlation of BPD and childhood trauma. This shows that there have been studies after studies highlighting the importance of adverse childhood experiences in the development of BPD. The main issue here is recall bias. Some people with BPD may not even realize that they've been traumatized from not wanting to realize that traumatization has occurred because of what it means to the person. The brain might have tried to forget the trauma, and the person might not be in a safe space to be able to unpack what happened. The individual might not realize that even small amounts of maltreatment over the years accumulate and might have a bad adverse effect on the person, or they don't want to acknowledge that they were traumatized. Even if the person is traumatized in childhood, a stable attachment style and a stable environment with validation of their emotions, the person might not end up developing BPD or a trauma-related disorder. What's important is how your body reacted to the trauma, not how you perceive it. As of now, there isn't enough evidence to put BPD in the category of trauma-related disorders. And still, at least half of the people diagnosed with BPD report childhood trauma. That includes me. What I can say though, through this research and living with BPD, there should be an incorporation of the presence of childhood trauma, and attachment styles should be incorporated into the model of the creation of BPD. They should be seen as a high risk factors for developing BPD. Also, with that in mind, the first line of treatment for BPD being DBT, it has shockingly no mention on how to heal from childhood trauma. DBT should include trauma-informed therapy module. What can most certainly be said is that a large group of people who are diagnosed with BPD report some kind of childhood trauma. There is a high risk that people who grow up in an invalidating environment or an environment where they cannot obtain healthy coping skills and go through some kind of maltreatment or trauma, they may very likely develop unhealthy coping skills that can turn into BPD.